You may have heard reports of seemingly healthy young athletes like footballers suddenly dropping down dead in the middle of a game. Well, Professor Paulus Kirchhoff from the University of Birmingham studies the genetic defects that lead to this condition, a rare form of heart disease which exercise actually makes worse. I wanted to find out more, so I started by asking him how big a problem this condition really is.
On average, 1 or 2 professional footballers per year in Europe drop dead on the pitch. The famous example 2 years ago was Fabrice Muamba, who, fortunately was saved. I think, first of all, it's important to emphasize that regular exercise is good for almost all of us. So you should all, if you listen to this, know that exercising for half an hour or 45 minutes a day is very good for you. There are a few people who are born with genetic defects that predispose them to heart disease that can cause sudden death. And interestingly, a few of these heart diseases manifest in athletes. So when you do competitive sports, you are more prone to develop ventricular arrhythmias and sudden death. And the 2 main cardiomyopathies that are affected here are hypertrophic cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy. This is a very long word and you don't have to remember it. It is a gene defect that is found in genes that code for the proteins that glue our cardiomyocytes together. So people who have this disease have a tendency that their cardiomyocytes, their heart muscle cells, detach from each other. And this process is probably aggravated by training because of the higher workload that the heart has to do.
So how would the heart of someone who has this genetic defect look different to the heart of someone who doesn't?
Well, for ARVC, the pathologist finds that in the right side of the heart, in the right ventricle, the heart muscle cells are almost absent, and that the only tissue that holds the heart together, that prevents it from rupturing, is fibrous tissue and fatty tissue.
If we're having these people just dropping down dead, that suggests that they hadn't noticed anything wrong coming up to that. Are there no symptoms?
It is amazing how much a normal body, and especially an athlete's body, can compensate. So most people with that disease are not aware that they have it. And unfortunately, the first symptom is sudden death.
Is there a way of detecting this disease before people drop down dead?
The International Olympic Committee actually recommends some screening, and the recommended screening consists of an exercise tolerance test, where an ECG is recorded during exercise, and an ultrasound heart scan, an echocardiogram. And if these 2 are normal, the presence of one of these cardiomyopathies is very unlikely.
So if we know that this is caused by a genetic deficit, is there any way we can treat it?
You have to understand how the gene alters the cardiac function, so in our case the heart function, and how it actually leads to sudden death. And we usually do this in the lab. Mice and zebrafish are very helpful techniques to explore that. And once we have understood the function and the cause of the dysfunction of the gene defect, we can think about devising therapies.
So how do you go about studying this in mice? I assume you don't have them playing football.
No, we don't have football trainers for mice. But if you allow mice to swim in a group, they actually enjoy that quite a bit. And if you help them in a sort of training program by allowing them to swim a little bit longer every day, you can actually make them swim for 90 minutes per day. And it actually induces all the changes in the heart that we would see in competitive athletes. So what we have found in the last years is that if you have a reduced expression of some of these genes, and one of the genes involved is called plakoglobin, if you have a reduced plakoglobin function, then your right heart has a tendency to dilate and to develop ventricular arrhythmias. If, however, during training you take medications that reduce the amount of fluid in your body, water tablets as they are called for the treatment of hypertension, you can actually prevent that. We do not know whether such a treatment is safe and or effective in patients who have these gene defects. And this is where we currently are. And we are in the planning stages of a clinical trial that tries to test whether preload reducing therapy, water tablets, can actually prevent the progression of ARVC. And should that trial be positive, we would finally have a treatment for these patients.
So why do you think that tablets designed to help with water retention might help with this kind of disease?
let's just think about the heart as a layer of cardiomyocytes. And people who have this gene defect have a less stable glue that glues these cardiomyocytes together. When you are training, you need a lot more blood flowing through your body so that the heart is distended. It's almost like filling a water balloon 50% more. And this distension then puts an undue pressure on these weak glue connections between the heart muscle cells. And then they probably rupture, and this is when they either die or their function is changed. And if you now give a water tablet, you will actually reduce the filling of that balloon. You will reduce the filling of the heart to a certain extent, and you will thereby prevent the excess distension of the heart muscle cells, of the heart muscle, and thereby possibly prevent the damage to the heart. But that's only a theory, and as I said, we can show that it works very well in this model, but we still have to prove that it helps patients.
How long do you think it'll be until this tablet might be on the market for people with this gene difference?
The good thing about this is that the tablet has already been on the market. These are standard water tablets that have been used and are used to treat, for example, high blood pressure in millions of people. So we know that they are relatively safe. We definitely will need a few more years, and that's probably more 5 to 7 than 1 to 3, until we know whether we can give this therapy safely to patients with these gene defects and whether it actually prevents the progression of the disease.